Okay, thank you very much for your comment and introduction. Now we have another presentation that I would say is much more simple than the previous one, because the previous one comes from a very long debate of the last 40, 50 years. This one is more limited to some pharmacological and clinical aspects. This one is limited to a specific point that in any case is not marginal because it's very common. Probably some of you are familiar with my work on meta-analysis that was mentioned before. And this is what we have done in the last 10 years, among other lines of research, to try to understand how the antidepressants differ. We did also for the antipsychotics and mood stabilizer, but mainly for the antidepressants. The big question is, we have 41 antidepressants, depending on the country, some country less, some country more, but 41 antidepressants. Which one we should use? This is the main topic of many of my meta-analysis and work. And which one we should use is based on a lot of consideration in terms of tolerability, side effect, history of the patient, clinical picture, and so on. Today, we focus on one specific point that has never been presented in congresses because it's coming from a very new study. So you are the first audience that is listening to this specific analysis here, the gastrointestinal side effects. Why gastrointestinal side effects? Well, because they are the most common. And in fact, we were surprised that we did a lot of meta-analysis in the past about weight gain. You can see them in the literature, sexual dysfunction. We did the meta-analysis on insomnia, agitation, sleepiness, but we never did a meta-analysis on nausea and gastrointestinal side effects. And so it happened to us about 1 year ago with my collaborator. I say, oh, Vincenzo is the one that did Vincenzo, but we never did a meta-analysis on gastrointestinal side effects. I was thinking to some of my patients that in that period had some disturbances in the stomach and the bowel. We should do it. There is nothing in literature that is useful. Okay, so we did this meta-analysis. Like the other one, the importance of this meta-analysis is due to the fact that if patients take an antidepressant and they are not happy with it, they can stop the antidepressants, they can hate the antidepressant, or they can take antidepressants one day yes and one day no. In any case, a bad attitude. And I can tell you that if you are taking a pill that should treat your depression, and remember that depressed people are not very confident in the treatment, and this pill is not giving any benefit for 2 weeks, but for the 2 weeks gives a lot of nausea, gives a lot of constipation, gives a lot of diarrhea, obviously the patients are not happy at all. Therefore, it's important for us to know which of the drugs give more or less these disturbances, and we can discuss with the patient. Typical sentence that I use is, listen, in my opinion, you have a severe form of depression. Don't worry, quite common, we can treat it. There are many options. No one option is clearly better than another. They are differing in terms of side effects. Some of them can give you more weight gain, some of them can give you more somnolence, some of them can give you more nausea. And after discussing this way with the patient, it's always very easy to understand what the patients want and what don't want. Sometimes it's quite funny because when I discuss with these words, exact words, I see the patient say, oh, no, 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 this nausea problem is not a problem for me because I'm eating too much, so I would like to eat less. Nausea is okay. I don't want sleepiness because I have to drive my car. And this is a very straight answer. So it means that for this kind of patient, we will not give mirtazapine, but we will give maybe escitalopram or something else. So this clinical, practical sketch is to make you understand how it's important to match the desire of the patients and our prescription to avoid lack of compliance and dropout. But to match, we have to know which of the compounds do the effect or not. And this is why we are working on this, to help you to know which are the differences. Few slides on the background, because we have to understand what is behind all of this. First, you may be surprised that 95% of serotonin is produced in the intestine, not in the brain, and is produced there at all levels. And this serotonin, bowel serotonin, is communicating with the brain. The bowel-brain communication, as we will see during this presentation, is much, much more than we expected. In the last 10, 15 years, everybody was surprised to see how much is the communication between these two systems. It's bidirectional. Brain can change the bowel, bowel can change the brain behavior. At many levels, including the last one that we will discuss at the end of the presentation, the microbiota. I will introduce it now, but we will discuss later more in detail. Microbiota, you know, are the 2 kilograms of bacteria that we have inside our gut. They are very different kind of bacteria, but they are very useful because they change things and produce substances that are needed for us, but they can be also harmful and produce inflammatory cytokines that gives us a sense of fever, a sense of weakness, a sense of insomnia, anxiety. And therefore, it's very important to modulate the bacteria in the gut. We will see this also later. But before going to the bacteria, let's stop to the serotonin. Serotonin changes things in the gut mainly through 2 receptors, serotonin 3 and serotonin 4. The question that is starting to be complicated is that the serotonin 3 and 4 have opposite effects. So if you block serotonin 3 and you activate serotonin 4, have peristaltic reflexes. And so from this line, you start to understand how complicated is the effect of antidepressants on the gastroenteric system. Because when you increase overall serotonin, you have a cascade of opposite effects. You don't have only nausea, you have nausea and constipation, depends how much you increase serotonin, it depends how quick is the reaction of the organisms, depends on many other pharmacodynamic system, noradrenaline, acetylcholine. I will try to show you briefly later, and the microbiota, of course. So just to have an idea what happens there, serotonin is secreted on the lumen, and then it immediately causes movement and peristalsis. So it is really involved in this peristaltic movement of the bowel that leads to constipation, nausea, and so on. And therefore, serotonin is extremely important in all the aspects of the gut. But not only, motility is one that is probably the most important, but also sensory, secretory, the messages to the central nervous system, also bone formation. And when there is an imbalance of serotonin on the right side, we have many unfortunate conditions like inflammatory bowel disease, irritable bowel disease, celiac disease, also to the risk of cancer. So serotonin is indeed clearly important. And therefore, all the drugs that we have that modulate the gastrointestinal functioning, they modulate the serotonin system and transporters, mainly serotonin receptor 3, that is the one that is more active on it. But not only, they also other compounds go on the serotonin receptor 4 and so on. This is the whole list of the serotonin receptor. As you see, is huge. Maybe you cannot read it all, but the idea is to tell you how complex is the situation of the serotonin modulation of the gut. So when you think, well, with serotonin reuptake inhibitors, we increase serotonin in the synapses, and therefore we do something in the gut. No, because you stimulate all these different sub-kind of receptors. Some of them have opposite action. So it's not completely clear what happens if you increase serotonin in the gut. And this has been demonstrated by the knockout mouse. If in an animal you delete the serotonin transporter and therefore increase serotonin, they alternate periods of constipation and diarrhea. Because it seems that there is a very complex relation of stabilization with all these subreceptors. But the most important are the 3 and 4. And indeed, the 3 and 4 are the ones that are used in clinical practice. As you see from the slide, only 3 and 4 are used in clinical practice, metoclopramide and ondansetron, because they are both antagonists on serotonin 3 and agonists on serotonin 4. So it is the maximum prosynetic effect. And we all know that when we take metoclopramide, the effect on the stomach and the gut is very, very, very clear and very good. Good, depends on what you want. Okay, said that, let's focus on what happens when we take antidepressants. Mainly SSRI, of course, because tricyclics is different. When you give antidepressants, you stop the serotonin transporter. When you stop the serotonin transporter, you increase serotonin. When you increase serotonin, you increase the activation of serotonin 3 and 4. And now you know that the increase of serotonin 3 and 4 gives an opposite effect, but opposite doesn't mean zero. Depend which of them prevail, in which area, in which section, in which changing of time. And this depends on the degree of the rapidity of the adaptation, desensitization of the mucosal serotonin receptors. Because when you increase serotonin, the postsynaptic receptors reduce, of course, their presence. And this is what I told you before, when you do experiment in the mice without serotonin transporter, that means a lot of serotonin, alternating diarrhea and constipation. That is what we see in many of our patients. Obviously, tricyclics are different because they are very anticholinergic, and so they just slow gut transit, mainly. Maybe clomipramine a little bit less, but imipramine, amitriptyline, they slow a lot. I had 2 patients that with amitriptyline had a problem, a serious problem of constipation, a very long constipation of more than 1 week. They had to go to the hospital. So tricyclics can give a very strong constipation because they are anticholinergic, of course. And let's start to the first answer. After 10 minutes or so, now we are in the center of the presentation, the most important part. This is not one of my meta-analyses. They did it before us, but still it's interesting. They compared the overall risk of digestive side effects across SSRI. And it's different from what we have done because we have divided to any kind of side effects, nausea, diarrhea, anorexia, and so on. But let's stick to this because it's interesting all the same. All side effects. Okay, you can read it the same way we were reading the previous slide in the other presentation, starting from the bottom, placebo. We can see 2.4, 2.8, 4.3, and so on. The last number say very clearly that all, and I mean all, antidepressants have some gastrointestinal effect clearly more than placebo. All of them. First take-home message. Second take-home message. They differ. Which is, you can see, the one I would ask to my residents, which is the antidepressant that gives more gastrointestinal side effects? Obviously, sertraline. Sertraline with this 4.29. And this makes sense because we know in clinical practice that sertraline is indeed giving relevant gastrointestinal issues, particularly diarrhea. And the one that gives less is escitalopram. And this also makes sense in terms of clinical practice. But these are overall, combining nausea, diarrhea, constipation. And if you consider internal comparison, the only relevant are that escitalopram is probably better than sertraline, and escitalopram is probably better than paroxetine. Makes sense, because paroxetine is anticholinergic, so it's giving a lot of constipation. Sertraline is giving a lot of diarrhea. All the other comparisons are not significant. So this is a first very useful, in my opinion, piece of information for you and for me when we have to avoid gastrointestinal symptoms. But let's go on. There was another study in literature before we did our study. Is a population study. And this population study results are interesting in the same direction. It seems that the use, the first line on the right, here the laser is not so powerful, you cannot see. In the first line on the right, antidepressant use gives gastrointestinal symptoms with an odds ratio of 1.9. That is in line of what we are expecting. This is a population study, so all the population, not just a sample. But in this study, they realized that if you control for many other conditions, the effect of the antidepressant is much less relevant. If the patient had symptoms before, for example. And it makes sense because it's difficult to differentiate in a population study someone that is having nausea for the antidepressant or for someone that is having nausea for anxiety or for substances or anything else. So this underlines how difficult it is to do this kind of epidemiological studies. This is why last year we did this meta-analysis with Vincenzo, I told you. Consider that to do this meta-analysis is very difficult because they, and I say they because more than one, have to work for about 1 year, scanning a huge number of papers, 1,000 papers, 2,000 papers, to find papers that are relevant, should not be excluded, and then code the papers. It's a huge, huge job of meta-analysis. But this was not existing in the world, so it was important for us to do it. Gastrointestinal gastrointestinal effect of antidepressants. First finding. We always put in the same style like the old meta-analysis in ranking. Which is the antidepressant that gives more diarrhea? Sertraline. This is very common knowledge. We all know it. We all tell the patients, oh, this is a very powerful treatment. Don't worry, it will help you, but consider that during the first few days or weeks, you will have an increased diarrhea. You don't worry about that. It's a normal phenomenon and so on. The usual thing that we say during the consultation. The second similar is fluvoxamine, but with a very wide standard deviation, so the sample is probably too small. Clearly lower is escitalopram, lower again is citalopram and duloxetine. And the explanation is probably very clear because both citalopram and duloxetine have some kind of anticholinergic side effects. And therefore the anticholinergic counteracts the serotoninergic with a different mechanism. So it gives less diarrhea. While sertraline is not anticholinergic at all, it is not servo-controlled. You have the serotonin 3 effect without the cholinergic control, and therefore it gives more diarrhea. And we will see in the last slide how the pharmacodynamic profile of each compound is very useful to understand what will happen in clinical practice. You can read through the lines and then understand what's really happening. Constipation, the opposite of diarrhea. Who is more responsible for constipation? It's not surprising as well because we see what there's venlafaxine and duloxetine and venlafaxine. So the noradrenergic compound, we know that noradrenergic is not giving diarrhea compared to the serotoninergic increase, and they have also some kind of anticholinergic effect. And therefore, it's not surprising that they mainly give constipation. And going down to the one that give less constipation at all, that are bupropion and vortioxetine. And this is also not surprising because vortioxetine has no anticholinergic effect at all and has a milder block of the serotonin transporter. So it makes sense. And it makes sense the fact that bupropion has no serotonin modulation at all and there's no cholinergic modulation at all. So it's working on dopamine, purely dopamine. And so it has almost no effect on constipation. So with these first two slides, you already have some very useful information for your work since tomorrow. When a patient is asking you, please doctor, don't give me drugs that give me diarrhea, or the opposite, please doctor, don't give me drugs that give constipation, and you have some information about how to choose. But let's go on. Nausea. Nausea is very troublesome for many patients, probably even more than diarrhea and constipation. I have patients that complain a lot about their nausea or vomiting sometimes. If nausea is so strong, they vomit. Which are the compounds that give nausea and vomiting more than the others? We see on the left duloxetine and vortioxetine. Levomilancipram is not much used because it's not in many countries. But let's talk a little bit about these two, duloxetine and vortioxetine. Well, in my opinion, there is also a slide later. In my opinion, the nausea with duloxetine and vortioxetine is highly dependent on the dosage. For example, vortioxetine nausea, you see a lot above 15 milligrams. Yes and no at 10 milligrams, no nausea at all below 10 if you go slowly up. Similar for duloxetine. Duloxetine at 30 milligrams is very unlikely that there is nausea. So duloxetine and vortioxetine give nausea, but it's much dose dependent. Venlafaxine, reboxetine, sertraline, fluvoxamine. Fluvoxamine is quite low in this analysis, while fluvoxamine is known to give nausea. I don't know, probably the numbers were so small, meta-analyses are not always perfect. And the ones that give less nausea at all are the ones that have some anticholinergic activity. So paroxetine, citalopram, that lead to weight gain usually because they don't give nausea. Bupropion, as usual, is in another ward, is in dopamine, and fluoxetine also because it's mainly dopaminergic as well. Anorexia that is linked to nausea but is a little bit different. Uh, in this case, we have fluvoxamine clearly high. And this high position of fluvoxamine on anorexia is very interesting because it is linked with our results of 10 years ago in our meta-analysis of weight gain, that fluvoxamine is not responsible for weight gain. And it makes sense. Fluvoxamine is giving anorexia. They don't want to eat too much, therefore they don't gain weight. Makes sense. Similar venlafaxine, desvenlafaxine, and the other are quite similar one to another. There is not a big ranking here. And finally, the dry mouth. Dry mouth that is clearly linked to the anticholinergic effect, obviously. So we see on the left the noradrenergic and the anticholinergic compound, on the right the ones that they don't have it. So this is very simple from a logical point of view. And then in the end of the article, we made this table that you can take from the paper, and I always suggest, like our previous meta-analysis, you can keep it in your office. So you can have a very watch some summary of the situation. When you have a picture like this, you can navigate with your patients in front of you about what to do. If a patient tells you, oh, doctor, please don't give me anything that gives me nausea because really I suffer too much of it. Wonderful. We can work on the first column and choose the right one. And the same for all the other. You want a problem, you don't want a problem of constipation, and then you work on the third column and so on. The only one that seems to have no problem whatsoever for the many gastrointestinal issues is mirtazapine, obviously. But mirtazapine is giving the opposite, is giving a lot of increased appetite. Mirtazapine is not serotonin transporter. Mirtazapine is blocking postsynaptic serotonin receptor. We all know that mirtazapine is just giving antidepressant effect, anxiolytic effect, and appetite. So I'm very proud and I'm very glad that we put this in the end of the paper because I think it's very useful. I remember in the previous meta-analysis, I mean, other audiences, they were very happy to have such kind of summary in the end of the paper. And that summary is the summary of the evidence that comes from the real reason why those drugs are different. In this table that you cannot read, but is not needed for you to read, you can see in the distributed slides, and you can read at home tonight. This is the pharmacodynamic profile of the antidepressants. And having understood which are the mechanisms that lead to nausea, constipation, weight gain, all the others, if you read the line of each of these compounds, you understand which will be the clinical consequence. So, for example, we are looking at mirtazapine. Mirtazapine has no affinity for the serotonin transporter. Okay, so I will not have any of the serotonin-related side effects. Very mild for the noradrenaline. Okay, not at all for the dopamine transporter. Okay, so you already imagine that the mirtazapine is not an activating antidepressant like bupropion. And then you go on, you see that there is a very strong affinity with the histaminergic 1, very strong with alpha, very strong with muscarinic, and therefore you understand that mirtazapine is giving a lot of increase of appetite, a lot of sleepiness, a lot of reduction in anxiety. And this is perfect because this is what we want. But you can have also opposite desire. And so if you move across the lines, you choose the perfect antidepressants for your patients. So we are going to the end of the presentation. Nausea and vomiting are quite common in antidepressants SSRI. Only one is not giving this kind of side effect is mirtazapine, and we explained why. And many of them have a dose related effect. When you increase the dose, you see the effect, otherwise you don't see it. Two final slides about what to do when you have gastrointestinal side effects in your patients. First suggestion, use divided dosing, not just one pill in the morning, but try to divide morning and afternoon. Very simple. Second, try to take the medication with food. It's not clear why, because it should not be a contact effect, but it seems to work. Third, you could use some anti-ulcer treatment. Fourth, you could give some drugs that counteract the pharmacodynamic effect, like promethazine or ondansetron. Finally, you could combine with mirtazapine, that you have a booster in antidepressant effect and reduction on nausea. For constipation or diarrhea, you could do similar strategies, antidiarrheal agents, change the microbiome, physical activity and counseling about food and things, and the usual easy laxatives. The last 2 points are, first, despite the fact that antidepressants can give some gastrointestinal side effects, they can also cure some gastrointestinal disorders because their effect is balanced. I had many patients with irritable bowel disease that recovered almost completely with SSRI. And this underlines the complexity of the activity of SSRI in the bowel. Very complex, with hormones that go down, hormones that go up, and all the other possible interactions. And this is the final slide of my presentation. That is a review that we just submitted. Hopefully, I can discuss maybe with you this next year, where we demonstrated the bidirectional effect of antidepressants in the microbiome. We saw very interesting things, that microbiome in depressed patients is different from normals. There are less species, is somehow more poor. And when you give antidepressants, it enriches. So antidepressants seem to work also in changing the number of bacteria in the bowel. And this is probably a mechanism of healing because they change inflammation and they change neurotransmitter production to the brain. So consider this that I told you in this 1 minute an abstract. We will discuss maybe more in detail in next meetings. But microbiome is very important. So in conclusion, antidepressants have a variable but relevant gastrointestinal effect. But they also can treat some gastrointestinal disorder. They are heavily modulated by microbiota. For sure, subgroup of patients differ. Some of them have the side effects, some don't. At present, we have to do empirically. In the future, we could use genes and genetic profile to know it in advance. Thank you, and for ready for questions. Yeah. Very nice, Philip. Yes, everybody likes it. Yes. Microwave. You know, like the movies, like the movies. Next year. Yes, yes, yes. Yes, that's great. So they will talk about the whole. I would like to see that. Yeah. Hey, good to see you. No, they were interested. Nice. Okay, hope that the record is good.